Thank you for joining us. I'd like to welcome you to CPT and PCS Spinal Anatomy and Pathology. And you'll notice we have two presenters today. So, this is our first dual presentation of 2021. It's my pleasure to introduce Christy Pollard and Deanna Upston, both of which have incredible accolades and acumen in the coding and auditing realm. So I won't give you specifics on them if they're new to you. But without further ado, I do want to welcome Deanna Upston.
Hi, everyone. Thank you guys for joining us and spending an hour with us to go over CPT and PCS, spinal anatomy and pathology. Um, this is my first webinar of 2021, so I'm super excited, and I'm really excited to be presenting with Christy. And Christy is driving the presentation for us today, so just don't mind my comments if I say next slide or something like that. So we're gonna go take a look at the agenda. So again, this presentation is gonna kind of do a deep dive into anatomy, which is what I'm gonna cover, and then we'll go into spinal disorders, which will be covered by Christy. And as you know, a picture is worth 1,000 words, and there are a lot of pictures in this presentation. It's super hard to talk about anatomy and spinal disorders without a visual. So hopefully you guys enjoy that and we'll get a lot out of it. And you know, seeing the agenda here, just some highlights of what we will be talking about. You will know and understand the difference between vertebral segments and joints. By the end of this, you will be able to identify components of the anterior and posterior column of the spine. You'll know the individual components of a vertebral segment. And you'll be able to differentiate between the super confusing terms of spondylosis, spondylolysis, and spondylolisthesis. So with that, let's jump into some anatomy. Thank you, Christy. So this first slide gives us the basic foundation that everyone needs to understand. The spinal regions. We have the cervical spine that starts at the top. There are 7 vertebrae. Then the thoracic spine, which has 12. The lumbar, which has 5. And then you have your sacrum and coccyx, which do have vertebra, but they're fused into one solid bone. And I absolutely love this fun way to remember the number of vertebra in each spinal region. If you think of breakfast, lunch, and dinner, you start the top of your day, you have breakfast at 7 a.m. Then in the middle of your day, you have lunch at noon or 12, and dinner at 5 p.m., which would be your lower spine, the lumbar, with their 5. And this cute little giraffe is going to be following us and helping us throughout this presentation. And just a fun fact, giraffes have 7 cervical vertebrae, just like humans do. I imagine they're quite a bit larger, but I found that very, very interesting. So we'll go on to the next. This is a really good slide. This is a good documentation tip or for any coder that they should know, are these acronyms. So examples of segments. You're not going to see in your op report cervical spine first vertebra. You're going to see it abbreviated as C1 or C2. And then the same thing with thoracic spine. They're not going to say thoracic vertebra 12 or dorsal vertebra 12. Dorsal is the same thing as thoracic, just FYI. They're going to abbreviate them with T12 or D12, and lumbar is just going to be L. So L4 is the 4th lumbar vertebral segment. Alternatively, you will see examples of joints or interspaces referred to as you see on the slide. So C6, 7 would be representing cervical vertebra 6, 7. Or T4 to T5 or D4 to D5 would be referencing that space or interspace or joint between thoracic vertebra 4 and thoracic vertebra 5. Then there's the transitional vertebral joints, or the transitional regions. So when the cervical spine transitions to the thoracic, so it would go from C7 to T1, your first thoracic vertebra, that would be referred to as C7 to T1. And the same thing happens in your transition between the thoracolumbar region, so T12 to L1, and then the lumbosacral, which is L5 to S1. Again, this is important to understand this because this is how it's going to appear in your op reports. Additionally, many diagnosis codes, CM codes for intervertebral joint or disc disorders have codes for the transitional joints. So like the L5 to S1, so that transition between the lumbar spine and the sacrum, in addition to the non-transitional joints, so the L4 to L5. And then PCS body parts has different body parts for the transitional joints. So this is just really good. This is kind of how we'll be talking about these as we go. So C1, C2, T12, L4, etc. Just knowing that means cervical, thoracic, or lumbar. So this slide is just kind of a quick talk about the vertebral segment. Each of them are different, a little bit different in size or shape because of the purposes they serve. The lumbar vertebrae are much larger than the cervical vertebra because they carry the weight of the body and they connect it to the pelvis. As we go through, we'll be using lumbar vertebra to describe the anatomy that is common to all segments. The only segments that are truly distinct are C1 and C2, so your first cervical vertebra and your second cervical vertebra. And we're going to discuss these on the next few slides. So I find these bones particularly interesting. They are actually kind of amazing. The C1, or your first cervical vertebra, is also called the atlas, and C2, your second cervical vertebra, is called the axis. These bones help attach your head to your spine. They enable movement. And think about all of the different ways your head can move. It's pretty incredible that these two bones can facilitate the movement of your head, right, left, back, forward, around, up, down. It's just ingenious. And this next slide, we kind of dig into this C1, or the atlas. And by the way, Atlas comes from the Greek term Atlas, who was the Titan Greek of mythology who supported the heavens and whose picture appeared on the front of early atlases. So this is actually a perfect name for this bone. The atlas connects the head to the spine, and you can see on here where the head will rest, and it's just perfectly shaped to hold everything at the base of your skull there, and to still have room for the nerves. And then the next slide, that C2, the atlas. So this has, where you see the dens, that actually is a protrusion. The technical name is a tooth-like structure, which that pokes up through the C1, and the C1 sits right over it. And it just perfectly, they fit together like a perfect puzzle piece and allow movement in all directions. This allows the head to pivot just like an axle. So these bones, we were talking earlier, you may not see operative cases on these two bones. Unfortunately, if something happens to them, it's not going to fare well for the patient very often, but it does happen, and these bones can be fused, fixed, if necessary. So, but hopefully none of us ever find ourselves in that situation. And the next slide. So we're going to pause here and talk about the vertebral segment. We're going to go over this anatomy here in detail. Again, this is an example of a lumbar segment, as it's a bit larger, so it's a bit easier to see all of the components to it. And again, most vertebrae have the same basic shape, except for the ones we just talked to about the C2 and the C1. So each vertebra has a spinous process, which is a bony projection off the posterior or back side of the spine. So the spinous process protrudes where the lamina of the vertebral arch join and provides a point of attachment for muscles and ligaments of the spine. So most of these things you see here, they have served multiple purposes. They serve purposes for attachments for muscles and ligaments, and they also protect your spinal cord and your spinal nerves. So after the spinous process, which is towards the posterior or back, then we have the lamina, which is the flattened or arched part forming the roof of the spinal canal. The posterior part of the spinal ring that covers the spinal cord or nerves. And then we have the two transverse processes. They extend off each vertebra in the spine, one on each side. This is where some muscles and ligaments attach to the spine. One of these muscles is the psoas muscle, which controls forward bending motion of the upper body and thighs. And of course, things you will see may be documented in an op report as part of an approach. Additionally, each vertebra has two cylinder-shaped projections, which are called the pedicles. They're hard bone that stick out from the back of the vertebral body, providing side protection for the spinal cords and nerves. The pedicles also serve as a bridge joining the front and back parts of the vertebra. Then we have the facets. They are found on the superior and inferior, so upper and lower aspects of each vertebral segment. These allow articulation with the other vertebra. So this is where the joint motion really comes from, is your facets. They are a synovial joint that are lined with cartilage. They are lubricated in synovial fluid, and a healthy facet joint will glide and slide smoothly back and forth with the ones above it and below it. The other main piece is the vertebral body. So it's part of the anterior column of the spine. It's a thick oval segment of bone forming the front of the vertebra, also called the centrum. The cavity of the vertebral body consists of cancellous bone tissue, and it's encircled by a protective layer of compact bone. The upper and lower surfaces of the vertebral body are flat and rough to provide attachment for the intervertebral discs that lie between them. So you can see on this slide, the vertebral body is on the anterior part of the spine when you're looking at it from the side, and the top. It's a pretty large piece compared to the posterior elements. So we're going to go on now and talk about the intervertebral disc. We all maybe have heard the term, but it is your spinal shock absorber. It lies, as I said before, between the vertebral bodies, and there are two components of your intervertebral disc. There's the outer part, which is the annulus fibrosus ring, and then there's the inner, and it's the nucleus pulposus. And again, this is a very important piece of your spinal column, as it just keeps the vertebra and everything cushioned and no impingement on your nerves. And when things go wrong with these, as Christy will talk about later, it can cause a lot of pain and problems. And it looks like this brings us up to our first polling question.
Awesome. I'm going to go ahead and read it on the screen so you can see those images, and then I will launch it. So, which structure are the arrows pointing to on these images? Is that the spinous process, the transverse process, the vertebral body, or the intervertebral disc? So let me go ahead and launch so you can, hopefully you got to look at that image and go ahead and answer. Let's see if we can we definitely have one running away. Folks are engaged. Let's go ahead and see how we did. So Deanna, 85% say that is the vertebral body.
Really awesome. Good job, you guys. That is absolutely the vertebral body. if you remember, the spinous processes were the bony projections off the back, and the intervertebral disc is the um, shock absorber that it's soft tissue, lies between the vertebral bodies. So, but yeah, really good job. Most of you got that right. It is the vertebral body, part of the anterior column of the spine. Okay, so moving on. So piecing together the puzzle. So this slide shows how individual vertebral segments fit together with the spinal cord and nerve roots like a puzzle. It's really perfectly designed. If one vertebral segment is out of place or has excessive bone growth or the discs degenerate, so there is loss of disc height, the result is impingement of the spinal cord or nerve roots where they pass through the neuroforamen. And again, we've included so many pictures because it's really hard to paint the picture of the 3D nature of the spine with just 2D pictures. The vertebral segments themselves are complex and have a lot of components, and then how they fit together to form the puzzle and the protection around the spinal cord and nerves is so precise. So this next slide, we really get into the I feel like this is a super important concept to pick up, which is the vertebral segment versus the inner space. If you're coding CPT for prophy or PCS for facility, this is a super important concept to understand. So terms that you may see that will refer to the vertebral segment would be the bone or bony part, the vertebral body, or the vertebra itself. And then terms that would refer to the interspace, so between the segments, would be joint, the vertebral joint, the disc lies between them. It's also referred to just as intervertebral or interbody, and interspace, although it's not on here, but interspace is also used to refer to that interspace. These all refer to that. And CPT does provide definitions of this. So in CPT, if any of you code CPT or have a CPT book, in the spine section, it will define these as a vertebral segment. Describes the basic constituent part into which the spine may be divided. It represents a single complete vertebral bone with its associated articular processes and lamina. A vertebral interspace is the non-bony compartment between two adjacent vertebral bodies, which contains the intervertebral disc and includes the nucleus pulposus, annulus fibrosus, and two cartilaginous end plates. Also, just kind of another tip, speaking to CPT, the CPT arthrodesis code descriptions are written with the terms interspace and vertebral segment alternately used. So it can be confusing when you're trying to count how many levels should be reported when you're assigning CPT codes. So kind of look past the terminology, focus on the anatomy. Fusing a single level technically includes two vertebrae and the interspace or joint space between them. A single vertebra could not be fused to itself. So a good way to count levels in spinal fusion is to count the interspaces or the joints in between rather than the actual vertebral segments. And again, this next slide just continues to drive home the point I was just talking about. The context really matters when you're looking at operative documentation. You might see L4, L4, 5. So this could refer to either two bones or one joint. In examples is you might see L4, L5 laminectomy. So that could be lamina removed off of two vertebrae, so two bones. But if they're talking about L4, L5, L4, 5 discectomy, that is the interspace between L4 and 5. So that would be one joint. So I hope that, this all makes sense, and looks like we actually get to practice a little bit what I said, with our next polling question.
You got it. All right, so polling question 2, the patient had a fusion of L1 to L3. How many joints were fused? Is that 1, 2 or 3 joints? So give everyone a couple of seconds. If you're with a group, you can get consensus and vote on behalf of the group. All right, let's see what folks say. So we have 81% that say that is 2 joints, 6% say 1, 13% say 3.
Great, most of you got it right. It is 2 joints. There are 3 vertebrae, so 3 bones. But remember, when you're fusing all 3 of them together, it's crossing 2 joints. So if we can bring up that image, that slide again, and Christy can show you. So we have, again, the 3 bones, but what we're actually fusing are the joints in between. So that's 2 joints between those 3 bones. So this is a pretty, it can be a confusing concept to get. So kudos to all of you that got it. And hopefully the rest of you can keep this presentation as a reference and a resource to help remember, because that's a super kind of hard concept to get. So good job, you guys. So now we have covered most of the bony anatomy that you need to know associated with the spine. So there's another really important part of the spine, which is the nervous system part. So beyond the bones, we have the spinal cord, which is the central nervous system. And you can see that spinal cord goes right through those vertebral bones where it's nice and safe and protected. The spinal cord is covered by meningeal layers. And then we have the spinal nerves that protrude out off of them. They are part of the peripheral nervous system. And they are named for the region of the spine where they arise. So example, the lumbar nerve. Understanding the anatomy of the spinal cord and nerve roots is important when coding procedural decompression, especially in CPT, because decompression codes are picked based on decompression of the spinal cord and or nerve roots. So seeing where those nerve roots come out there is key. They're also important for coding the epidural injections. Injections into the epidural space are coded as central nervous system in CPT and PCS. And then the transforaminal epidural injections are placed at the nerve root as it exits the spine. This is coded as peripheral nervous system in CPT and PCS. We do have more detail on the spinal nerves and plexuses on the next screen. So here you have the intervertebral and the neural foramen. The intervertebral foramen is the hole in the middle of each vertebral segment where the spinal cord goes. Then the neural foramen is the space between the vertebral segments where the nerve roots come out. Again, this is important, particularly for PCS coding, because decompression of the spinal cord codes differently than decompression of the spinal nerves. The spine on the left shows a compressed spinal nerve, where the image on the right shows a compressed spinal cord. And again, in CPT, the decompression codes encompass a single code for decompression of the spinal cord and or nerve roots. So on this slide, you see more additional terminology you may see, especially in the CPT decompression codes. It's called the cauda equina. It's Latin for the horse's tail. The cauda equina is a bundle of spinal nerves and nerve roots making up the 2nd through 5th lumbar vertebra down into the sacrum and coccyx. It's a bundle of nerves grouped together that look like a horse's tail, hence the name cauda equina. These nerves are responsible for innervating the pelvic organs, lower limbs, internal and external anal sphincter, perineum, and bladder. There is actually a rare but serious condition associated with the cauda equina. It's called cauda equina syndrome. And this would occur when the nerve roots of the cauda equina are compressed. And this would disrupt motor and sensory function to the lower extremities and bladders. Patients with this are often admitted as a medical emergency and taken directly to the OR for decompression. This can cause permanent incontinence or paralysis. So kind of rare, but it is very serious when it happens. So on this slide, you're seeing a real clear distinction between your anterior and posterior spine. The giraffe is shown in the same position as the spine on the left. The red line represents the spinal cord, which is what determines if the fusion is anterior or the posterior column. So anterior towards the front, posterior towards the back. And on this slide, you see common patient placement during your surgery. So there can be usually either placed supine or prone. We're going to talk about surgical approaches on the next slide. This will lead into it. So it's important to note that the anterior spine, that anterior column, can be accessed from the front or the back. The posterior spine is only accessed from the back. So any posterior spine fusion type procedures, you would expect to see your patient placed prone. There is a Jackson frame that you will see often documented. It's used in spinal surgery. It's adjustable to get the patient placed in the proper position and not move. And here you see all the acronyms for surgical approaches to spinal fusion. And this is a really handy, definitely if you code spine surgery, keep this, hang it up by your desk, whatever you need to do, and definitely look at these arrows where you expect to see the surgeon entering through to get to the spine. You have the ALIF or ALIF for anterior lumbar interbody fusion. OLIF, OLIF is the oblique lateral interbody fusion. Then you have ATP, which is anterior to psoas. That's that psoas muscle I mentioned earlier that attaches to the posterior elements of this vertebra. Then there's the XLIF, extreme lateral interbody fusion, the DLIF, direct lateral interbody fusion, and the TLIF, or TLIF, transverse lumbar interbody fusion, and then the PLIF, posterior lumbar interbody fusion. Something important to note, some of these anterior approaches will be done by two surgeons. Often a maybe thoracic surgeon or a general surgeon will do the approach, and then the neurosurgeon will actually do the fusion because it is so technical entering from the front, and there's so many organs that a neurosurgeon, you know, their specialty is the bone and the spinal column, so they will call in a specialty surgeon to help with that. So with that, I get to turn it over to the brilliant Christy to talk about common spinal disorders.
Thank you, Deanna, and thanks for giving us that quick primer on the anatomy stuff. I get to talk about spinal disorders. One note that I'm going to make before I get into this is that this is the first in a couple of different series of webinars. Deanna will be back in, I think it's March, if I'm not mistaken, to talk about CPT coding for spinal fusions. And I will be back for the next 3 months. So this is taking me up all of first quarter into April with basics of spinal fusion, intermediate, and then advanced. The feedback that we have gotten from you all as our listeners is that these are really hard to code, particularly on PCS. And so we've decided to break it down a little bit more. In any time we do a webinar on spinal fusions, we spend so much time talking about anatomy that we really felt that it was possible to do an entire webinar just on the anatomical stuff. We've never done that before. We've always included a lot of coding information, but hopefully you guys are finding this very useful, and it does play into the spinal series that we're doing for both CPT and for PCS. So if you, in case you hadn't figured it out yet, Deanna's our resident CPT spinal expert. I am more on the PCS side of the spinal stuff, but there are so many aspects of spinal anatomy of what we need to know that apply to both CPT and PCS. And I don't feel like we can really talk about, take this into our further series without talking about some common spinal disorders and what can go wrong with the spine. As Deanna walked through the anatomy of the spine and each vertebral segment, you can see where things can really start to go wrong. If you get any pinching on the spinal cord, either from a breakdown of the joints, a breakdown of the disc, or an extrusion of the disc so that it's pressing on the spinal cord or the nerve roots, it causes a lot of problems. You can also have problems where the nerve roots exit the spine and they get pinched. You can have breakdown of those facet joints. As Deanna mentioned, they are your typical joints, synovial joints with fluid and very similar to your knees. You can get degeneration in your facet joints, and then you've got vertebral segments that are starting to rub together. So we're going to talk about some of these. And while I don't have CM codes attached to these in the presentation, I will talk a little bit about some of the nuances of that come into play with CM coding, which would apply whether you are coding this from a CPT or a PCS perspective. We all have to know how to code the CM stuff. So if there's anything in this presentation today that you feel like we left out, or if you'd like to have a presentation just on the CM coding, because I know that can get confusing, just drop us a comment either in the chat window or on your survey at the end of this so that we kind of know how to go from here. So I can never tell if I'm on the right screen for changing or if I'm just lagging. Maybe a little bit of both. I'm not sure if it's me or the computer that are lagging today. So let's start with the term spondylosis. Spondylosis is degenerative joint disease of the spine. And there are a couple of other things your physician might call this. You might call it osteoarthritis, of course, degenerative joint disease. If you look up the terms osteoarthritis or degenerative joint disease of the spine, it will take you to the same codes as spondylosis. This word is so very important because it's so close to another word that we're going to talk about here in a minute. But this is just the general breakdown of the spine, and it's something that occurs in people as they get older. I think it's almost impossible to avoid this. And it can occur with or without myelopathy or radiculopathy. And those are terms that become important with CM coding. We have a lot of combination codes throughout the spinal section where myelopathy and radiculopathy are a component of the code, and really understanding what these conditions are, how everything fits together is important. So in the picture we have here on the left, we've got a normal spine. You can see we've got nice thick discs so that the bones are not compressing on each other. Everything looks good. The nerve roots are exiting normally. On the right, we have an osteoarthritic spine where we've got some narrowing of the disc space. We start to get the development of bone spurs. And with that, we also get this bone on bone. And because the discs are the shock absorbers of the spine, this is going to start to cause a lot of pain, and you don't have that shock absorption anymore. Radiculopathy, also known as radiculitis, and I think there's a lot of confusion from coders, or maybe I'm just projecting my own, educational thing on everybody else, but they are terms that we read. We see them in operative reports. We see them as part of the code assignment, but do we really know what it is? And it's a pretty simple concept. So radiculopathy is kind of the manifestation of this compression on the nerve root or the spinal cord. Radiculitis is compression of the spinal nerves and the nerve roots. And when I say spinal nerves, don't confuse that with spinal cord. As we mentioned, the spinal cord is part of the central nervous system, but the spinal nerves or the nerve roots are where those nerves come off of the spinal cord and then exit the spinal column and go to innervate different parts of the body. Radiculitis, that compression on a nerve root, results in pain that is going to radiate down from that nerve and then go downstream. A big example of this is sciatica, something that we hear about often. Maybe it's something that you have experienced yourself, and it's very painful. So it's usually one-sided because it's compressing the nerve root on one side, and then it goes down into all the way down the leg. The symptoms of this would be pain, numbness, tingling, and weakness in the arms or legs. If it's up in the cervical spine, it's going to affect your arms. If it's down in the lumbar spine, it's going to impact your legs. So radiculopathy is that compression of a spinal nerve, whereas myelopathy is compression of the spinal cord. And what you get then is compression or pain and symptoms that are going to be more severe than what you would see in a myelopathy. Then you start to have problems with walking, increased reflexes and spasticity, clumsiness with the hands if it's occurring in the spine, muscle weakness because you're in pain, so you're kind of not using your muscles as much, numbness, and possibly even paralysis. So these are, myelopathy is a much more severe manifestation of what's going on. And it can help the physician kind of determine what it is that's happening with the patient and determine how to move forward and treat that. Now, I mentioned that spondylosis is a really important term, and that's because there's this other word that for so long in my coding career I thought was the same thing, and it is not. It's spondylolysis. Spondylolysis has a little extra LOL in the middle of the word. So spondylosis is degeneration or osteoarthritis of the spine. Spondylolysis is something very different. So on the posterior part of your spine, you've got these a small segment of bone called the pars interarticularis that joins the facet joints in the back of the spine. And its purpose is to prevent the spinal segments from slipping forward. And I wrote a blog on spinal anatomy in preparation for today's webinar that's available on our website if you haven't read it. One of the things that a colleague of mine said once is it's not so much that the spine is three-dimensional, it's more like it's five-dimensional. And when you think of everything that could possibly go wrong, I'm fascinated by the spine and how it keeps everything together. But when one thing goes wrong, it can cause a lot of other problems. So spondylolysis, and again, it's got the LOL in the middle, but it's no laughing matter because spondylolysis usually results in spondylolisthesis, and that's where you've got that slippage of that vertebral segment forward. And remember, you've got a spinal cord that's moving down through the center of those bones. When one of those bones is displaced and pushed forward, then you get compression on the spinal cord, and there can be a lot of problems associated with that. This can be degenerative, so you can have spondylosis and spondylolysis that leads to spondylolisthesis. And I think spondylolisthesis is a little bit easier to differentiate. Again, look for that LOL, which is no laughing matter. This can also be the product of trauma, and I have seen this from traumatic spondylolisthesis, which does have a separate code in ICD-10-CM, where the patient has, anytime I hear somebody broke their back, oh yeah, he broke his back, he broke his spine. What did he break? If he broke, if it's a spondylolisthesis, that's really serious, really severe, potentially. If he broke, like my brother broke his back several years ago in a motorcycle accident and ended up breaking off a couple of, I think it was the transverse processes. It was the tips of the transverse processes, which wasn't great. It still caused some pain, but it didn't cause compression on the nerves or the spinal cord. And most of the time when we're coding spinal fusions, I know when we do my PCS portion, we're going to talk a lot about spinal decompressions and spinal nerve decompressions. That's really the ultimate goal of most of the spinal surgeries, is to relieve that pressure on the spine and spinal cord. When we get into coding, and I've seen this question posted just in chat groups on social media, or posted in some different places, can I code spondylosis with spondylolysis with spondylolisthesis? And this is where you're really going to need to focus on your excludes notes in CM. You can code spondylosis with spondylolysis. Those are two different conditions. You can code the two together. You can code a spondylosis with spondylolisthesis. Again, two different conditions. One is saying I've got degeneration of this joint. The other one is saying I've got slippage of the vertebral segment. But there is an excludes one note for spondylolysis with spondylolisthesis, because if you have spondylolisthesis, you have spondylolysis. Hopefully that makes sense. I know that was a whole lot of spondylos and spondylese and LOLs and stuff like that. So with that, we'll see how well I did in that explanation with a polling question. Jen?
All right, last one. So, what is spondylolysis? Oh my gosh, I said it. Osteoarthritis of the spine, a crack or defect in the pars interarticularis, or slippage of the vertebral segment. And I will always remember that LOL is no laughing matter. That is such a catchy little thing. I love those because it helps you remember. All right, let's see how everyone did. So 75% say a crack or defect in the pars interarticularis.
And that is the correct answer. So that is the crack or the fracture of that pars interarticularis, which can lead to the slippage of the vertebral segment, but it's the listhesis, spondylolisthesis, that is the slippage. And osteoarthritis, while it's also no laughing matter, does not have the LOL in the middle. Arguably, I think that the defect in the pars interarticularis, depending on the severity, is more concerning than the osteoarthritis, because it can lead to that slipping. All right, thank you so much, Jen. So spinal stenosis, and I think, as I talked about the excludes one notes when it comes to coding multiple different spinal conditions, it's worth noting, because how many times do you open up an operative report and the first page is just a list of the patient's diagnoses and the procedures that were done? It's not uncommon. You can have, and if those diagnoses are numbered, you could have 4 or 5 or 6 or more diagnoses there, and it's like, oh my gosh, I mean, this just seems like overkill. What do I code? And it's really important for us to understand what these different conditions are, but then also make sure that we are applying the excludes one notes in CM. That's why they're there, to help us figure out what we should and should not be coding together. So with spinal stenosis is a narrowing of the spinal canal. And that conversation, is it a conversation since it was just Deanna talking? Deanna's monologue about pressure on the spinal cord versus on the nerve root is not just important in CPT, it's also important in PCS. We do have different body parts depending on which structure is being decompressed if we're working on a decompression procedure. So spinal stenosis is a narrowing of that central spinal canal so that we've got an encroachment on the spinal cord. And, can this occur with other conditions? Absolutely. This can occur with osteoarthritis or spondylosis. This can occur with any type of disc disease. So usually, I don't think there are any excludes one notes for spinal stenosis with other spinal conditions. It's something we should pick up. Moving on to, we've been talking a lot about bone defects. So the spondylosis is where we kind of, it does affect the joint in that it's a degenerative joint disease, but we get that formation of bone spurs on the vertebral segments that then makes it also kind of a bone disease. But when we talk about degenerative disc disease, it's different. So can you code degenerative joint disease with degenerative disc disease? And the answer is yes, because they are two different conditions. There are no excludes notes that prevent you from doing that. So don't confuse this with degenerative joint disease, because it is something different. This is where we start to have breakdown of that disc, and it leads to a loss of disc height. And I don't know about you, is anybody experiencing back pain yet today? Because anytime I start to look at this, it makes me more cognizant of my posture. I am standing up right now because I feel like when I sit for too long, my lumbar spine gets compressed a little bit down, and then I worry about loss of disc height and all these other things. Well, when you get this degeneration of the disc, that's your shock absorber, you start to get that crunching down in the vertebral joint, and now you could potentially end up with bone on bone. With that, as those bones start to collapse and you get that loss of disc height, those spinal nerves that are coming out the neural foramen on each side start to get pinched. You are potentially also pinching the spinal cord. You could have osteophyte formation or spur formation that leads to spinal stenosis. So you can see why your operative reports have 6, 7 different diagnoses at the top of the op report, because if these conditions have been going on for a long time, they can cause a lot of different issues, a lot of different problems. So a herniated disc, also known as a herniated nucleus pulposus, or an HNP, is what you might see documented in a report, an operative report. This is, what else do we call it? Slipped disc. Herniated disc is what we commonly hear. And there are varying levels of this. So in the anatomy portion, Deanna talked about how we've got that center core of the disc called the nucleus pulposus, and the outer ring called the annulus fibrosus. So as the term suggests, annulus fibrosus is a very thick fibrous structure that's going to prevent that nucleus pulposus from squishing out. The way I think about this, and I think about almost everything in relation to food, but it's kind of like a Three Musketeers bar. So the inside squishy part of the Three Musketeers bar is the nucleus pulposus. The annulus fibrosus is the chocolate. So and the reason I'm using a Three Musketeer bar is because they squish pretty easily. So if you start to squish a Three Musketeers bar, you know, it kind of bulges out, but if you don't apply too much pressure, then the chocolate doesn't break and the nougat inside does not squish out. But if you keep pressing, then you're going to get a break through the chocolate and you're going to get the nougat squishing out all over the place. So what you see in varying degrees of a herniated disc is you could have a bulge. So here our annulus is bulging out, but it's not broken through, so that, you know, that slight compression on our chocolate, but it's not broken until you get into this extrusion where that outer annulus fibrosus or the chocolate is breached, and then you have the squishing out of the nucleus pulposus and the core of that. Now, as that happens, if you look in the lower picture here, this is the spinal cord, and then we have the nerve roots coming off of that. If we have this, depending on where this herniated disc is located, if it can either press on a nerve root, the spinal nerve, or on the spinal cord itself, or both. And there will be situations, usually when they do a decompression during a surgery, it's the nerve root that they're decompressing, but some operative reports you will see them talking about relieving pressure on the spinal cord, or even the spinal cord and the nerve root. So there you go, spondylolysis, LOL, no laughing matter, and herniated disc, Three Musketeers bar. Sorry if you want to jump out now and get a Three Musketeers bar. So scoliosis, and this is where we have received a lot of our questions from a PCS perspective on coding for spinal fusions that are also correcting scoliosis, and that is something we will be discussing in the PCS series. So scoliosis is an unnatural curvature of the spine. And when I think scoliosis, I think lining up in PE class as an elementary student. We would line out outside the PE teacher's door, and then we would all go in one at a time, and the school nurse would, you know, check our spine to see how straight it was. I don't know if they still do that, but it was, you know, something where if they could catch it early, they could fix it and do something to keep the curve from getting worse. The problem with scoliosis, which usually affects the thoracic spine, is that you get curvature of the thoracic spine, which is also where your rib cage is located, and you can start to get compression on the lungs. It can really interfere with the patient's breathing. There's so many different procedures that they do for scoliosis now. Some of them are not just spinal procedures. Some of them involve putting spacers between the ribs to help kind of, you know, keep that rib cage elevated so that they can then move the spine back into alignment. Sometimes they do fusion. Sometimes one of the big things now is they can put magnetic rods into the spine. So it's a one-time surgery where the rods go in, and then they are able to adjust them with an external magnet it's done in children. So as the child grows, they are able to help straighten that spine, but this device then grows with the patient instead of having to go back and having rods put in all the time. So scoliosis, that abnormal side-to-side curvature or an S curve of the spine. Ankylosing spondylitis. So we have spondylosis, spondylolysis, spondylolisthesis, and spondylitis. Are you keeping track of all this? Do I always remember all of these? Not all of them. Sometimes I do have to do a quick Google. But itis means inflammation. Spondylo refers to spine. So this is inflammation of the spine. Ankylosing spondylolysis, which may also be referred to as ankylosing spondylosis, is a form of arthritis where over time you start to get this breakdown, you get excess bone formation, and then you get fusing of the spine, not from a surgical procedure, but your spine just starts to fuse and it starts to look like bamboo. So if you've ever looked at a piece of bamboo, this is called bamboo spine. This obviously is going to cause lack of flexibility, loss of flexibility. It could cause hunched posture if your spine fuses in the wrong position, and difficulty breathing. Again, anything that affects the spine in the thoracic region can also impact your breathing, and it can because of the location of the ribs. Compression fractures. Compression fracture is a type of fracture where, and a lot of times it's associated with osteoporosis, where you get that softened bone and then you start to develop these cracks within the vertebrae. As Deanna mentioned, the inside of the vertebral bone is filled with that spongy bone. So if you get a cracking in the outer covering, then it starts to compress down. There are a couple of different procedures they do for this. They can do a vertebroplasty where they inject PMMA cement, polymethyl methacrylate, and it kind of fills into all of the cracks and helps to, keep it from compressing even further. A kyphoplasty goes one step further, where they drill into the bone and they inflate a balloon inside there to kind of lift the vertebral segment back up, and then they fill that void with PMMA cement. That's called a kyphoplasty. And the new one that's out right now, there's a new PCS code for it in 2021. And I think I just saw a new code for this in CPT as well, for a spine jack. And really cool procedure where they put in what looks like a jack that you would use to jack up your car to change the tire. And it goes in and it pushes that segment up. So there's your compression fractures. Other types of spinal deformities, which I'm not going to spend a ton of time on, but I think these pictures speak 1,000 words. You have kyphosis and round back. You should have a certain curvature in your spine, and this is a front to back. A lot of times with patients with kyphosis, it is because of a disc height issue, so they may do a kyphoplasty to fix that. This is the one that reminds me to kind of stand up straight. How many times did your mother tell you to stand up straight, or you're going to end up hunched over like that old person from school or church or whatever? And this can cause a lot of problems. And then flat back syndrome. Again, you're supposed to have a certain curvature in your spine. This is the opposite of kyphosis. So instead of having that extra curve in there, you've got less of a curve. This can cause a lot of problems with balance because it kind of pitches you forward. It really can mess with your whole stature. And then lordosis, or sway back. And I think a lot of these images make more sense if you kind of look at them side by side. This is an inward curving of the spine, which can cause back pain, kind of makes it look like your buttocks are sticking out more. This is something that I think about when I've been sitting for a while at my desk, and I feel like I arch my back a little bit too much, which is 100% of the reason why I have a sit-stand desk right now. All right, so just to let you know that if you want to learn more about these, Spine Universe has an excellent anatomy database if you want to go in and look at more for the anatomy. World's Best Anatomical Chart Company is the company that makes those anatomical charts that you see in doctor's offices. They have some books that you can purchase, and they're not a lot of money if that's something that you're interested in and you want to learn more. And that is it for today. I know that we do not have time for questions today, and because Jen has a couple of things she needs to wrap up so that you know how to get your CEUs. I want to thank you all for joining Deanna and me today. If you do have questions, please drop them in the chat window or shoot me or Deanna an email, and we will get those answered for you. Jen, will you close us out for today, please?
You bet. Thanks, Christy. So as Christy mentioned earlier, this is the first in a series of spinal webinars for this year. So as she mentioned, Deanna will do CPT spinal fusions in March 10th. Christy is back for PCS spinal fusions February 18th. So if you are interested in more spinal fusion coding, definitely check out our website and get that full schedule. Joint replacement is going to be addressed on February 10th too. So we're not just about the spine. And then that last slide, I did want to make that quick plug before everyone runs. So you will receive a link in 48 hours, and that will give you access to the recording. And it'll also give you access to the test. So if you do have anyone that attended just the recorded webinar, they didn't attend live and they need AAPC CEUs, they do have to take that test. So wanted to make that plug. And then immediately following today, a webinar will pop up. So please take a second, give us your feedback. We are always looking for what you liked, you didn't like, and we do develop new training based on your feedback. So please let us know. And thank you again. Thanks for joining. Thank you, Christy and Deanna. And we hope to see you all back next time.